Hi, Chintan. Good evening.
Hi, Srini. Good evening.
So thanks for joining this, very interesting CIO podcast by DHL. I think this gives a different way of avenue for us to share and exchange the ideas, how we can improvise the whole healthcare system. So again, thanks to DHN, for giving this opportunity, and thanks to you, and for sparing your time to have a conversation on this. I think, how are you? So first of all, like.
Yeah, I'm fine. Thank you, Srini. And good evening to everyone. This CIO to CIO conversation.
Just to give a quick introduction of Aravind Eye Care System, and so we are predominantly kind of focused in southern part of India, okay, Tamil Nadu, and some part of Andhra Pradesh and Pondicherry. So specialized in eye care. We provide only eye care services. One of the largest eye care provider in the world. We provide in complete comprehensive eye care, like it's one stop, for the entire eye care. So in a day we see around 20 to 22,000 patients, providing outpatient services. And we also do 2,000 to 2,500 surgeries, in a day. So, I mean, that's the scale. And by the way, I also manage a separate IT division called Auroitech, which comes under Aravind Eye Care System. So Auroitech builds the platform, the healthcare platform for eye care services. So when I say eye care platform, which includes the application, IT services, whatever required for eye hospitals. It was started as it was a part of Aravind Eye Care System. Then over the period of time, we felt, again, this is an ethos of an Aravind, where we wanted to share the best practices of the, to the rest of the world. And our vision is eliminate needless blindness. And our founder thought, this vision cannot be done only by Aravind, and we need to build the competition. So that's where he decided, why can't we share the best practice to the rest of the world? So through which the Auroitech started to build the IT solutions for eye care, and we provide to the rest of the hospitals outside of Aravind, even outside of India. In the past, in fact, our platform being used 150 hospital, outside of Aravind. And today with our, a revamped platform, with the products being used around 30 hospitals in outside of Aravind. So I manage both Auroitech, the whole IT solutions and development, and I also manage the complete, IT service for Aravind Eye Care System. Okay, so I play a role of CTO for this organization, with 30 plus years experience in the industry, predominantly outside of India for almost 20 years, managing the big accounts, kind of the worth of $200 million to $300 million of account. And my major focus was more on the technology services. I was with an IBM for 12 years. Then kind of handled some of the telecom, banking, financial service, in insurance. So and then I came back to India around 2008. Subsequently here, I've been focusing on more on the healthcare sector in the past decade, actually. So that's in brief about myself, about my role, and our hospital. Yeah, why can't you share from your side?
So, Srini, myself, Chintan, I'm working with Shrimad Rajchandra Hospital and Research Center located at Dharampur. It's a part of South Gujarat, and
Oh,
it's a remote place, tribal area. So our organization motto is to serve the poor and needy people around the Dharampur and Valsad district. So we our focus is to just give a good quality care service to the patient, into the we can say poor patient, needy patient, and the substantially charitable price, or
mm,
we can say a charity organization or government scheme. Also we are working with the Ayushman Bharat also. We have
okay.
250 bedded multi-speciality hospital. So out of 250, around 80% we are treating under the Ayushman Bharat only. And we have also our outreach program. So we have 6 van. So we are going to the tribal and village area to the shoving to the patient or on their doorstep. So we have 6 outreach van. All the outreach van is equipped with the entire IT system and HMIS. So every data we are collecting is 100% digitally and paperless. And currently in our hospital also, our nursing activities 80% are digitally. We have
Oh, okay.
accredited the NABH. We have accredited digital NABH in platinum category, and we have enabled laboratory.
Predominantly, if you see the ecosystem, 50% of the patients they get free care, heavily subsidized care. Only 50% of patients take the paid services. I think we share the same kind of vision, both of
Yeah.
us.
So we can start with the our topic where you see the healthcare IT making real visible difference in Delhi hospital operation rather than just the system or reporting level.
See, today, very interesting challenge what we go through in India. One is, this is something like I share this everywhere. So 70% of the doctors are, in the urban areas. Only 30% of the doctors is in rural places, right? Whereas if you see, 70% of the population lives in rural. Only 30% lives in urban actually. So
Yeah.
it's a vice versa. So there is a shortfall of, the availability and accessibility for the real people like who need an access to the healthcare. We produce 70,000 doctors in a year. Okay. And, but in spite of that, today, I believe we have close to 1.4 million of doctors. But if you see, interestingly, almost 700 million people, okay, need to travel more than 5 kilometers to get an access to the healthcare. And the other hand, we see 8 million to 10 million patients are coming from overseas to get the service here. While there's a lot of improvement in healthcare, but the healthcare is not reaching to our own citizens. So this is where how the healthcare need to be kind of make it accessible, available, affordable through IT. So I think that is the IT is like a tool where this can bridge the gap, making it available, accessible for everyone. Okay, and making it affordable. Even our own specialty in eye care ophthalmology. Today, 39 million people are living as a blind across the world. And in India alone, we have 12 million people are still living as a blind. And in that, 80% of can be treated with simple surgery. So, and we can change them from blind to like us. But still, they are looking for a care from, that is a situation where our founder thought kind of how we can make it affordable and accessible for everyone. So he created two things. One is, you know, how I can reach out to my patient. That means in his language, reach out to the non-customers and how we can build the competition. We are all talking telemedicine these days. Okay. But we started this, early 2000 where we have something called a vision center where we go to the rural village and we provide eye care to the people in their place. This is achievable because of the technology. Because today, if you see the entire eye care services, it is not something like we place in the doctor, but we facilitate. So, what do you need typically? You need a clinical records to treat the patient. So those records are today completely digitized and that can be accessible, available any part of the world. So I think this is the fundamental shift of bringing the digital healthcare. So I mean, in my view, okay. So today it made it as a easily available for a nook and corner of every citizen, and it made it as an affordable for them actually. Okay, so in this, there are, when we think of this, we need to think only three things: scale, scalable, and accessible, and also it should be available. And beyond that, how we can make your eye care affordable through technology. One of the enabler is, the IT part. So, and it also brings the clinical efficiency, the workflow efficiency. So when I say workflow efficiency, your faster patient registration, triaging of the patient, your consultation workflows, and your data entry part, your OPQ management, your OT procedure and operations. So, I mean, these are all today, you know, kind of you made it as a system driven. You implement all these things in the system, and system drives it. So if it comes to our hospital, interestingly, if you see, like, we don't have any appointments. Okay. And it's just patients just can walk in, and imagine no appointments, it's completely walk in, and we see 20,000 patients in a day, and we do 2,500 surgeries in a day, and we have 140 locations in this part of the world. And it is something like when you get into our hospital, it's like pilot mode. So patient move clearly, like one department to another department, another unit, another department. So it is like autopilot mode. So because the way it is, the system what we have implemented, so the system guides the people. The system facilitates people, where to go, whom to approach. It is clearly, there's no chaos. There's a complete transparency in OP&Q management. There is no, like, what you call the bias in this. And even today, for the OT and the procedure and operations, I mean, everything is digitized. So when you do like so many surgeries, you need to ensure that you are kind of whatever the data what you are updating, you need to, it has to be synced with actual the work, so that has been captured in the EMR system. So, and apart from that, like, my view is, any hospital, we have three things. One is patient and the clinical team and the hospital. So a hospital includes a support group. So patient should have a clarity, patient should have a better experience, and the doctors need to have a the infrastructure to get the insights of the patient, that should facilitate. And your hospital cannot operate in silos. That means your stores and optical, your pharmacy, and other support, it has to be integrated with your main system, so which can be achieved only through.
Correct. I'm agree with you. So regarding our hospital, we have doing the same thing what you have explained. So today is a nursing day, International Nursing Day. So I just want to share one example which we are doing in our hospital regarding the nurses only. So earlier, what happened when the doctors go for the ward round, nurses has to write everything into the pad, and then they go to the nursing desk, and then again they have to re-enter into the HMIS or application. So we have implemented cow computers on wheel. So now what happened during the doctor round into the ward, they go with the cow only. So
Oh,
now
nice.
yeah. So currently what happened when the patient is there, data is also on the bedside. So now sister has to just punch all the entries from the bedside only. So duplication work we have reduced. Nurses can give more attention for towards the patient care only. Same
Exactly.
thing.
In our the way, like, the patient, when they come for a registration, we have given a app for them, where they fill all the details, so that the information is available before the registration, so that they get the ID card, and then system drives them actually.
Yes, and
Yes.
same thing we have implemented in our outreach activity as well. When we go to the outside or door to the patient, so at that time also our data entry operator capture all the demographic details, vitals. Doctor also give the record capture into the EMR. Pharmacist can give the medicine into the system based only. So entire workflow is a paperless. And if it is patient is required our hospitalization, so when the van will come to the my hospital, so automatically van data will shrink with the our production server or our hospital server. So whatever treatment has been given or prescribed by the doctor during the outreach, our hospital doctor can see entire EMR record into his system. And whenever
Okay.
doctor give additional investigation or report, all those could be shrink with the my outreach server. So when the next time patient come for the follow-up, so my outreach team or outreach doctor can know entire process which is done here into the hospital. So like this, doctor will be able to see entire patient journey during his visit. So that we have implemented in our hospital. We
Okay.
have
Okay.
integrated HIS with the PACS, LIS, and even for the account software and the pharmacy as well.
Okay.
So all we have integrated.
I think we share the same thing. Whatever you explained, outreach, these are all homegrown platform built by my team. We have the EMR IHMS, it's integrated, and it's also integrated with the lab information system, PACS, your stores, optical, pharmacy, and also the outreach, the program. So where they go out and capture the data and sync back to the backend system. So similar, we share the similar ecosystem with us actually. Yes.
Yeah. So we are doing the same. After the registration, sister has to enter the vitals record. Once the sister enter the vitals record, doctor can see the updated vital records during the OPD consultation. And whatever the
Yes.
doctor is order or investigation added into the system, respective department can see the entire details, which is laboratory, if it is pathology investigation, radiology investigation, or the pharmacy prescription, everything will be appeared to the respective department. We have also started the appointment on our OPD. So earlier, what happened? Patient has to wait so many long that time, and waiting time should be very high. So after that, we start giving this culture, develop the culture in our rural and tribal area. People here is like what you explained, Srini, walk into the hospital. So in this situation, there could be a very long TET time or waiting time. So we have start giving the appointment. After that, we facing that automatically the TET time is reduced, waiting time is also reduced. And nowadays, patient also happy. I have spent very less time for the consultation because I have already taken the appointment and all those things. So it will very helpful to us to implementing appointment system as well.
So how do you build the appointment system? Is it something through your, they come to your website and block the time?
Yeah. We have patient portal. So through patient portal, patient can take the appointment. Or we have a 24/7 support number. So you just have to call on this number because we are in the tribal area. So many patients are not be aware to how to access the application and all those things. So we have given 24/7 support appointment number. So you just have to call and book your appointment.
Okay. And how you get the data? Like you collect any unique identification number or just a phone number?
Yeah. So we have UHID. If the patient is coming first time, so temporary number will generate. And as per the temporary number, when the patient registered to the hospital, we are giving the UHID. And the same UHID will be remain for the all department. If the patient is go for the investigation, any pathology, radiology, or pharmacy, or even the admission is required. So during the stay, the same UHID number will be generating all the records.
Understood.
Even we have linked with your PAC system as well. So if the doctor has indent order anything related to radiology, so it will automatically reflect to my modality machine. Yes.
Which is correct. So what is your percentage of appointments like when compared to walk-in?
Yeah. So currently we have started this activity from last 6 months. So all the super specialty we have started the appointment. So we can say around 40% currently we are based on appointment only.
Oh, which is good actually. That is a good response.
So we are in the remote place, tribal area, so people are not very much familiar with the appointment system, but it will reflect so many waiting time down during my appointment system has been started.
That's great. Kind of I see the value there, value creation, what you did. So you're able to kind of in fact, we have a very interesting prediction system because the challenge is we need to prepare the resources, right? Suddenly, like a handling of 20,000 patients, of course, not in one hospital, from multiple hospitals, but still we need to do it. So we call it as a MLOPs, mid-level ophthalmologists, staff nurses. The way they predict, amazing. Like, you will see just 5 to 10% of difference. Otherwise they predict, considering the day and, whatever auspicious day or rainy day, they do the prediction and almost there. So now, in fact, we are trying to replace that with the AI, but still they're doing better estimation, actually, prediction.
We have also implemented AI in our EMR. So between the patient and doctor conversation, doctor just has to start the record. And whatever the conversation has been going on during the consultation, system will record all the conversation between doctors and patient. And once the consultation has been over, system will automatically pick up these related the information which is EMR. EMR is required. For example, let's say chief complaint, examination, diagnosis. Everything will be converted into the voice to text and into the drop down into the EMR. So that we have implemented in our hospital.
How long this voice to text dictation part is in operational?
2 to 3 months.
Oh, 2 to 3 months. So we have been put this in a pilot mode, in one particular hospital.
Yes.
So we are kind of receiving feedbacks. One is, the accent part we are trying to fine tune. So because we are capturing both the patient and doctor conversation, the conversation of local accent is something difficult to capture. That's the one thing. And also that's where we are trying to fine tune it. Okay. So what we do, we capture the whole thing, then we do the, just massaging the entire conversation, convert it as a text. And then again, the text is kind of picking the keywords, putting it back to the appropriate fields actually. So this is what we do today.
Correct. We are doing the same thing. Even our region, what happened, the people are speaking some local language, which is not the Hindi, not the English, not the Marathi. So at that time, the doctor will speak, understand the language and speak during the recording. So system will pick up those points at the time of recording.
Okay. What is the size of patient you see, in a day, your volume?
Yeah. So currently, around 500 to 600 OPD we are doing every day.
Okay. So, the coverage, right now you said in pilot mode in the last 2-3 weeks. So how many patients they go through this dictation process?
Around 100 plus every day.
Okay. So what is the feedback from doctors? They're comfortable with this?
Doctors are very happy.
Okay, that's good to know that.
Because it's saving them time and everything. And some of the feedback, which is what I get from our gynecologist, he has not assumed this feature will be pick up in details of like this, which is our software has given the result outcome of the conversation. It is giving into the very details.
So what else you do, you introduced as part of the digitization apart from dictation? What else?
So we have created one avatar, AI avatar. So as you mentioned, when the doctors can't reach, we give this avatar to our ASA worker and Anganwadi workers and even our outreach workers. So they go to the doorstep to the patient and you just have to ask your question to the avatar. So avatar will guide you what you have to do, what you have to do immediately action. And if the avatar find out this is the critical patient, so avatar tell you to just go to the hospital and contact your doctors immediately. So those kinds of features we have implemented. So Srini, in this implementation, what we have found when we started near about our hospital area, where the network and infrastructure are very perfect, at that time we can use this app or avatar. But when we go deeper, around 50 to 25 kilometers away from our hospital area, at that time network was not pretty, so avatar can't work properly. So for that we have created one more version which is only audio, not the video. Only audio conversation is there. Again, after launching this, we go to more deeper. At that time, we found that people does have the Android phone and all those things. So currently, we are implementing same model with the toll-free number. So if you have a normal call, a normal phone, then you just have to dial the toll-free number and my avatar will connect you directly on your phone and you can start conversation with the avatar. So
is there any reference for the patient, whether while talking they'll give their UHID number to,
No. We are not collecting any information from the patient or the user. You just have to start conversation. I have this problem, what I can do. He will give guide
general
you.
Information.
General information. And during the conversation, avatar felt this is a critical issue. You just have to go to your hospital or you need the immediate treatment, then he will guide you, just go to the hospital.
Okay. From our end, we are focusing more on the clinical side, rather, more on the kind of a patient supporting ecosystem. That's some anyway we need to do that. Good initiative from your end. From our end, what we do, like one is the typical the diabetic retinopathy, where I mean right, typically uh, it, the people who are diabetic, so they are prone to have a vision loss, so but what happened, like typically the people who are in rural, they may not know whether they are diabetic or not. So by the time when they come to a hospital, so they will have a severe vision loss and all those things. Actually, to prevent this, we built a model. Otherwise, what will happen, like so the patient need to come here and do the take the image, do the grading. It is a 2-3 hours process for each patient. We worked with the Google, and with their collaboration, we built a model. Of course, they helped us to build the model, and today that model, it is integrated in EMR. So a non-clinical person goes to village, takes the image, upload into the EMR, and the EMR will tell you, the criticality of the diabetic actually. So based on that, your further course of action will be done. This is one thing. Other thing is on patient summarization. Like let's say, see, that typically a patient visits 50 to 60 visits, for example, glaucoma patient or a chronic patient, like so doctor needs to go through the past history, then they select the date and choose it, it will take time. So what we did, we built a summarization. So irrespective of any doctor, so when they put a unique identification number, so this model will summarize all the past information, any critical information, so that doctor doesn't need to go through the past history checking by each date, so that it will save time actually. So
Oh,
this is one thing, summarization. We are in process of building a framework. Okay. The framework will deliver text to text, voice to text, and image to text. So the text
correct.
to text is something more like your prompt engineering. If let's say if my chairman or my CMO wants to know the particular patient information, or the data of the for that week, number of surgeries being done, number of patients came for that particular age, time, or particular location. So just to type English words, so that will be able to give on the response to it, rather they send a query to IT team and wait for that. So this is a one use case. Other use case is something voice to text we spoke, and the second one, third one is like the image. So let's say, like whatever the your OCT image, or the fundus image, you give it to the model, and it's something like it is not something like it will replace the doctor, but just to get in a second reference, and your model will provide the entire summary of the the image, so that it facilitates doctors to do efficient, spend more time with the patient and see more patients. So that's why we are trying to build a framework, so that, and we allow hospital team to build whatever the cases they want. Okay. See, the challenge for us in this process is, one is, this is something I want people to know. For any intelligence, data intelligence solution, you need to have a solid quality data and structured data. You need to have a standard data. That's where my challenge today. See, good thing is today we are sitting on a huge data that saves a lot of time. Okay, whatever the the solutions we are building, intelligent solutions using AI, we have a solid data to build. But the problem is, the kind of a data cleanup process to ensure efficient usage of the tokens, efficient usage of the AI engineer. Otherwise, you spend more time on the going multiple cycles. Okay, so then we thought, like why can't we build a data ecosystem prior building the AI solutions? So now, what it's being a not-for-profit organization, we have a right. Typically, we have a constraint on the budgets, because we need to think. This is a like as I mentioned, we have a 20,000 patients coming today. 10,000 patients, they get completely free, and we need to manage all these things, whatever money received by rest of the 10,000 patients. So we have the limitation. So we need to ensure like the entire ecosystem is built with the optimized efforts and optimized cost, so but with the in-house team. So that's the most interesting for me to play this role actually. So we use a lot of open source tools and open source models to build this. So but having building all these things, you need to have an efficient data ecosystem. So that's where we are kind of brainstorming ourselves. Can we do we need to build a data lake, okay, so that you don't play around on the production system. You get the copy of the entire production data system, and you do the entire data cleanup, data standardization in the data lake. Then you build analytics and models on top of it, so that you can play around with it without affecting the day, your production system. Lessons learned from this, when you build a system, when you build any platform and application, ensure your application handles the right data. That means managing this exception and the data entry itself, so that when you enter the data, you ensure system allows only quality data, and your system wants if there is any wrong data or in not a quality data actually. That is the biggest lesson. Now what we are trying to do, we are going back and building the all data entry areas. Okay, how we can bring quality data inside to the system actually. Purpose of digitization is moving from paperless to bringing intelligence of the clinical system actually. That is a paradigm shift actually. So digitization is more to do with the smart hospitals. So how I can decide any clinical decision based on the data. Okay.
Hmm.
So for which you need to build an entire ecosystem and the intelligent systems and your base products around it actually. So that's what it is transforming today. Out of all these things, your data security. So the data security should be in place. Your data governance should be in place. Okay. So your data structure it should be in place. Of course, these are all mandatory for regular your operational transactions, your queuing management system, your OPD management system. But now we are shifting the gears to the bringing outcome based ecosystem actually. Yeah, you can share your views on this.
So we have also doing the same practice. We have the live production area, and for the data and analysis, we have another one which we can say warehouse. When we get all the information from the all the applications or integrated application, and then only we can generate the report from the warehouse, which
Yes.
is not connected with the our production or live environment.
Mm, mm,
And in
mm,
one place, we are gathering all the information from the
mm,
HIS, from the finance,
mm,
from the I can say HR, from the pharmacy. Everything should
mm,
be gathered at the one place, which is secured, and from there only we generating the report and
mm,
share with the
mm.
our trustees and everywhere.
Okay,
Because
okay.
those kind of activity or report we have to need live tracking, because we are the charitable trust, so we have to manage our deficit and everything. So for that we have generated live dashboard through the warehouse only, where we
Mm,
can get all the information or all the data, and then
mm.
we recycle the data and populate that dashboard.
The whole digital transformations it should have focus today. A patient need to know, a patient should have a clarity, what is the process and procedure, and the patient wants to get it faster, and the
Hmm.
patient wanted to have access to their the services. They have a clarity on their services, and that's from the patient perspective. From the doctor's perspective, how we can provide insights for them through the data. Okay, so how much we'll be able to bring intelligent insights of the data, so for them to be able to decide faster. Okay, so that they can instead of prolonging a decisions, we need to enable them to make their decision faster. And hospital perspective, everyone wants to see like increase the patient footfall, but more than that, you know how I can integrate the silos of the across the organization. Okay, so how I can kind of eliminate the redundant work, how I can bring the efficiency. Okay, today, let's say entire ecosystem is seen, like let's say 2000 patients, with the same team, whether I'll be able to see 3,000 patients. So the improving the efficiency. Okay. So for all these things, leaders should have we need to facilitate the kind of a data and decision for the leaders to take a decisions actually. So that's where for all these things, you have the basic infrastructure of building products, then you need to have the data layer, then you need to have this governance, then data security. On top of that, you bring intelligence. Okay. So that's it, the entire the ecosystem. For all these things, you need to have a right team, kind of enable them to challenge the status quo. That is the most important thing. Okay.
I'm 100% agree with you.
I mean, another thing is what kind of a challenges you go through, Chintan,
Mm.
like,
Yeah.
the workflow challenges, because we've been talking all nice things,
Yes, yes.
let's have a quick conversation of the challenges.
Yeah, yeah. So regarding challenges, we have one big challenge is about the discharge time, because
Mm,
during the discharge process is very long. So currently we can say around 4 to 4.5 hours for the our discharge time. Because
mm,
currently what happened, we are treating 80% under the Ayushman Bharat scheme. So first we
mm,
have to complete the process in our HIS. Then all the records we have to upload into the Ayushman Bharat portal.
mm,
And when we
mm,
get the approval from the Ayushman Bharat, then only we
mm,
can finally discharge to the patient from the hospital. So during
mm,
both these process, it will take long time and long waiting for the patient for the discharge as well. So
okay.
currently, we are processing which we have under our control is our HIS discharge process. So we are working on
Mm,
it how we can do the fastest process in our HIS system, because
mm,
from the Ayushman Bharat, which is not under the our control. So
correct,
anytime
correct.
they
Yeah.
want to take, they will take. But whatever in
Mm,
our control, so we are just working on it, how we will reduce the our discharge time. So
mm,
for
mm,
that we are
mm,
doing some automation, which is give the discharge card directly from for the Ayushman Bharat user one
mm.
single portal. So from the portal
Oh,
they can download a complete entire patient history, discharge card, reports, everything. And one more
mm,
thing, Ayushman Bharat have some limitation, which is we cannot upload more data. So for that, we
mm.
have to compress the PDF file and everything. So
Oh, okay.
this automation will reduce the billing team's work, which is same portal you will get the reduced file, which is less
Mm,
than 2 MB or something like that. So from the HIS only you will get all the information which you have to upload on the Ayushman Bharat
mm,
portal. So single
mm,
click you
mm,
will get all the information. You just have to download and upload into the portal, which is we are
mm.
in the process and we are developing this thing. So for that
Okay.
maybe we can reduce 20 to 25% of time for the discharge process.
Oh, okay. 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 I understood. I think we are not there because we are yet to we are in process of adapting ourselves to the ABDM. I think that's a good that you shared your challenges so that we learn from that. From my perspective, the challenge is more from the of course, OPD management, I see kind of a more transactional, but we've been managing the patient's scale of 20,000 plus in a day. So we learned and we have been matured enough to handle these things, including the discharge and all those things. We are
Okay.
improving over the period of time. But my challenge is more on the user adoption to the workflow, EMR flow. User adapting is something like typical, right? Typically, so today young doctors and the young population is they are good at typing, kind of able to do that. But some of the users, so they're kind of struggling to adapt the
Mm,
flows.
mm.
So
Yeah.
expecting many kind of entry points, many data entry points, and identifying right flow. So the adaptability of the system. Okay, even though we provide a user UAT and all those things, but given their busyness, they're not able to spend time. Okay, so that's where, like, takeaway there is, you build the systems while using the system actually. So that means you even though, like, you don't get enough support in the UAT, and you take the risk of putting it to the user, and then user come back. So even though there will be some kind of a challenges to handle day to day, but over the period of time, this gets matured. So the one challenge is, from the user adaptability perspective, and they bring a lot of change, because one doctor wants this way, another doctor wants this way, you know, because each and every. So now we are thinking how we can handle these changes dynamically. Okay. So assuming that, give a, flexibility. Okay. So give a flexibility in the, workflow. So now we are kind of doing more research, bringing the configurability. So you make everything is configurable, whether your module or your screen or your until field level, make it configurable, and based on each hospital, you kind of enable, disable. So that is a one way. The other way is, since we kind of in the past it was a, legacy architecture, tightly coupled architecture, we had a lot of challenges. Today we built an architecture which is a modular, completely modular. Okay. It's a microservice architecture. You can do, like, all kind of barring some of the dependencies, you can play around it actually. So that architecture, gives a flexibility to, adopt the changes and dynamically. So that is a one way, we are trying to handle the challenges. Other one is, of course, I spoke on the, data part, ensure we get the right data, from everyone. So that's another part, like, what I would like to share. The third one is on the huge resource, whether it's infra or cloud or, the models, into adopt the AI part. So that the cost and, getting the resource, that's another challenge. So that's for which what I do, like, and I work with a lot of, universities, institutes. So they get, identify right talents, see, like, how we can collaborate. That's the way I work. So yes. So what do you, I mean, that's from my side.
So, Srini, regarding this adaptation, earlier
Hmm.
we are facing the same issue, but after some
Okay.
time we realized that, and what we have done the smart template for the doctors, and this
Okay.
is the specific to doctors, specific to department. If I have two gynecologists, so one gynecologist want my favorite should be like this, my medication should be like this, my chief complaint exam. So they just have to click on the screen. Once it is clicked, then system will patch the automatically chief complaint examination diagnosis. Even for the order also, we have created the favorite templates. If the doctors want to 4 5 investigation, so they can click and say single click they can order. Even same thing for the medication also, we have created the templates. So every doctor has around 12 15 item which is regularly they are ordering. So we have just a single click, and the order will be raised to the pharmacy or investigation department. So
Nice.
we
That
have
is
created
nice.
so we have created like this kind of facility which is department to department or doctor to doctor separately. If two gynecologists or two surgeon or two pediatric, two physician, everyone has different requirements. So accordingly we
Hmm.
have created given to the doctors. So
Okay.
through those kind of changes, they are adopting very quickly. Earlier,
Okay.
otherwise, we are facing the same issue. Also, for the nurses as well, what we have done, okay, one entry is available into the system. So, for the nurses, whatever record they have to maintain, the system will pick up automatically. So, balance only they have to feed. If the patient
Okay.
come to the emergency to the ward or ICU to the ward, so which is available into the system, the forms will pick up automatically, and balance only
Hmm.
they have to feed into the system.
Hmm.
So like
Oh,
this,
okay.
we have reducing these challenges, or we have
Very
uh,
interesting. Very interesting. Yeah, that is a good way to handle actually. So good. Thanks for sharing that actually. So
yeah.
the last one from my end is the interoperability challenges. How do you handle interoperability challenges?
So what we have done, we have defined the integration standard early, avoiding the isolation system and using the PIs. And for the
Good.
identification, we are using the unique identification from across the
Hmm.
platform.
So from our perspective, what we did, one is from the clinical standards, we have implemented SNOMED. Okay.
Hmm.
And
Hmm.
SNOMED, it is ensuring the standards of the diagnostics. Also facilitating, if someone is not ready for it, we allow them to give feedback in a free text, to capture that. Actually, you can also add your customized code. That's one thing. For packs, we follow the DICOM standard. Now we are in a process of kind of working on the HL7 to interoperable with the external. Otherwise, today we ensure we have a kind of mechanism where any data goes out, it is completely hashed, encrypted, anonymized, kind of. That is something clearly built in within the system itself. So
Okay.
in a way, kind of course there's a long way to kind of ensure, like, these are all automated, but these are all right now kind of taken care. Other thing is, now we need to work on the FHIR. That's something where, as a part of the complaints it's coming, so that's where we're working on it actually.
Okay.
So, and then last part is where we are heading. Let's say, like, next 5 years down the line. Okay, what is that something we wanted to achieve? Okay, probably you can share your views.
So for the next 5 years, our roadmap is to implement the DPDP Act first of all, which is coming this November. So we are under process to adopt the DPDP Act, and also we are making more patient-centric hospital, and also for the how we can reduce the time for the doctors and for the radiologists. Also we are trying to using any AI model which is give us the findings and reports for the radiologist. So it will reduce the my radiologist time, even during the consultation, how we can reduce the TAT time and give more patient centric to the good service or best service for the to the patient.
So I'll make it very simple. Okay, one is to make our product compliance to the standards, the
Hmm.
regulations, including ABDM, DPDP. Okay, then the GDPR, NABH standards. That's, of course, that is work in progress. The second is building the data ecosystem. Okay,
Hmm.
so that
Hmm.
your complete clean structured data is available for your entire analytics, for entire model building. Then we wanted to have our own GPT, so that it's like a completely federated platform built in, so that you know this model can be used based on the anyone's data, not kind of what can I say, uh, depending on the entire data. So the next 3-4 years, okay, end of next 3-4 years, we wanted to see that a complete digital smart hospital in place. Okay, so from end to end, from the patient to the clinician and support system, it's all completely connected, and it's mobile portable, and most importantly, it is secured. Okay, so secured, intelligent, reliable solution should be made available, accessible, affordable for everyone. Okay, even though I'm making it very simple, you understand how difficult this one.
Yeah,
So
yeah.
there's a lot of work to do actually. Okay,
Correct,
so
correct.
I enjoyed doing wonderful thing, Chintan. Like, amazing insights from your end. So quite impressed. Probably will connect in the coming days. So thanks for sharing your all insights. Kind of, I had a great conversation with you.
Thank you, Srini. Thank you for the meaningful and practical discussion with you. I learned so many things from you. Thank you. Thank you so much.
Thank you. Thank you so much. Thank you.